What's up, Ninja Nerds? In this video today, we're going to be talking about red blood cell disorders. That includes anemia and polycythemia. If you guys like this video, if it makes sense and you enjoy it, you know what to do. Hit that like button, comment down in the comment section, but most importantly, subscribe. Also, you want some amazing notes, illustrations, I highly suggest you check them out. Go down in the description box below. It'll take you to our website where you guys can follow along with me during this lecture. Now, this is going to be a little bit different than our normal lectures where we go into tons of detail about pathophysiology and we go down this rabbit hole kind of sometimes. In this video, this is going to be a really very systematic approach, a step-by-step approach of whenever you order a CBC on a patient, you see that they have signs of anemia or you see they have signs of polycythemia. What are the next tests that I should order? What would that test tell me? And then what we'll do is we'll do some case studies to really make sense of all of this. It's going to be quicker. It's not going to be a ton of explaining about things. I just want us to have a very systematic approach, and then we'll do repetition afterwards, okay? So let's get right into it. However, in order for us to understand red blood cell disorders, we have to have a little quick tidbit on the life cycle of the red blood cell. If you want more detail, we do have a video where we cover the whole life cycle and entire destruction pathway of the red blood cell in our physiology playlist. Go check it out in hematology. But for this one, we're going to keep it basic. When we talk about red blood cell production, it occurs where? In the red bone marrow. Yep, that's right. You got it. Now, in the red bone marrow, we start off with a cell called a myeloid stem cell. Now, the myeloid stem cell, what happens is it can become a red blood cell, it can become a platelet, or it can become what's called a neutrophil, an eosinophil, or a basophil. How does it know to go to become a red cell? Does it just be like, all right, I guess I'm going this way? No, it gets a particular stimulus. What are those stimuli? There's a lot of things, to be honest with you. What I want you to remember basically is it receives hormonal particular stimulus. It receives a lot of nutrients that are very essential for making a red blood cell. But you know what, unfortunately, we take drugs or we're prescribed drugs or there's certain toxins that we're exposed to that can actually inhibit red blood cell production. So remember, not only can we stimulate it, we can also inhibit it, unfortunately. And just remember, the bone marrow, the actual cells inside of the bone marrow have their own intrinsic type of activity. So here's what I want you to remember. We need particular hormones to drive red blood cell production. What are those hormones? First thing, thyroid. You need thyroid hormones, so T3, T4. If you have anemia, okay, you're not making enough red blood cells and there's a drop in hemoglobin, drop in hematocrit, maybe you have a low T3, T4. Your kidneys, your liver, it actually makes a hormone called erythropoietin. Erythropoietin stimulates the actual red bone marrow and drives red blood cell production. You need tons of nutrients from your GIT. You know what the three essential ones are that you have to know? One is iron, the other one is B12, and the other one is folate, also known as B9. These are essential in actually helping you to make red blood cells. Then, if we're exposed to particular drugs, there's so many, we'll talk about a few. Big thing, alcohol, or you're exposed to nasty toxins, they can actually suppress the bone marrow and inhibit the bone marrow from being able to produce red blood cells. So that's really important. The next thing that's also really important for the production of red blood cells is just the intrinsic bone marrow function. If somebody has some type of damage to their red bone marrow, they have a cancer, they have some type of destruction from chemoradiation, or they have a cancer where their bone marrow cells just suck and they aren't functioning and making red blood cells, that's a problem. So here's how I want you to think about anemia. Anemia is the low number of red blood cells, therefore a low hemoglobin and a low hematocrit. We'll write that down in a little bit, but that's what I want you to remember for anemia. When a person has anemia, they're not making as many red blood cells, right? Now, the way we can actually kind of really dig down into the details of anemia is anemia comes down to two different subtypes. You're either not having enough red blood cells, hemoglobin, and a good hematocrit inside your bloodstream for two reasons. One is your bone marrow sucks, or you're not getting enough hormones, nutrients, or you're exposed to a lot of drugs and toxins. And what happens is, if any of those things are present and your bone marrow stops working or stops functioning properly, can it go from a myeloid stem cell to erythroblast to reticulocyte to red blood cell? No. You know what's really interesting? At this stage here, right here, if we zoom in on it, going from a reticulocyte to a red blood cell, it's about 1 to 2 days. And so that's actually really important because this cell here, the reticulocyte, actually is a good indicator. We can actually test this to see how well the bone marrow is actually functioning. So what I can do is I can check the reticulocytes. Think about this. If we have low T3, low T4, low erythropoietin, low levels of these nutrients, lots of these particular drugs and toxins suppressing the bone marrow, or the bone marrow is destroyed, it's failing, it's cancerous and it's not working, think about what will happen to the production of reticulocytes. Will it go down? Yeah. So if the reticulocytes go down, then subsequently these will go down, but we'll pick this up earlier. So we can check something called a reticulocyte index, and that stratifies my two different types of anemia into a decreased production due to this issue or something else. What is that something else? Glad you asked. What if the bone marrow is working? No problem. You got normal thyroid hormone, you got normal EPO, you got normal nutrients, you don't got no drugs, no toxins. There's no problem with the bone marrow, it's working well and it's producing red blood cells, right? But the red blood cells get into the dang bloodstream and unfortunately you lose it. Why? I don't know, maybe because you end up with a GI bleed, maybe you bleed into your retroperitoneum, maybe you end up bleeding into your chest cavity, maybe you're getting frequent blood draws because you're in the ICU or in the hospital and they have to take and do blood draws every single day and they're just taking and draining your blood every day. Or you just got some type of surgical procedure. That's ways that you're losing blood. If you lose blood, you lose red blood cells. Think about negative feedback mechanisms, man, right? If we have low numbers of red blood cells, what do you think that'll do to this myeloid stem cell? It'll say, hey, we're low on red cells. Since you're functioning well, guess what? I need you to go ahead and start amping up production and jack that up and make more red blood cells, more reticulocytes. And so the retics will bump up if the bone marrow is working. So that's important. So one of the reasons we could have anemia, low hemoglobin, low hematocrit, lower blood cells, is because we're losing blood. And again, we'll talk about this retic index in just a second, but we're already kind of getting an idea that it should be higher because why? The red blood cells are low. If the bone marrow is working, all these things are good. The bone marrow should compensate and make more red blood cells because you're losing them. If it's the other end of the spectrum, where you're not losing them, you're just chewing them to pieces. They're getting into the vasculature and they're getting chewed up. They can get chewed up in two ways, and we'll talk about it in more detail for right now. They can get chewed up in the vasculature. There's many different reasons why it can get chewed up in the vasculature, or it can get chewed up in the spleen. When it happens in the vascular, we call that intravascular hemolysis. When it gets chewed up inside of these things called splenic macrophages inside of the spleen, it's called extravascular hemolysis. But either way, what are we doing? We're chewing up the red blood cells, dropping the number of red blood cells. If the bone marrow is good, these things are present, what will happen? The bone marrow should compensate and say, ooh, got to make more red blood cells. So what do you think the retic will happen? It'll go up for the reticulocytes. But you got to figure out why you're hemolyzing. And we'll go through and figure out all the different causes for that, right? But that's the big thing. So to put it all together, comes down to two different types of anemia. Anemia due to a decreased production. If it's a decreased production, what could be the issues? It could be decreased hormones, thyroid EPO, decreased nutrients, decreased B12, folate, and iron. It could be due to lots of drugs and toxins exposure. Think about alcohol as a big one. Or it could be due to a decrease in the intrinsic bone marrow function due to cancer, due to being destroyed because of a chemoradiation or something like that. If that's the case, the bone marrow is underproducing. Therefore, it's not going to make a lot of reticulocytes. The reticulocytes will decrease. The reticulocyte index is a formula. It's not worth remembering. Just what happens is the reticulocyte index is based upon your reticulocytes and your hematocrit and something called a maturation factor. What I want you to remember is the reticulocyte index in underproduction means that my bone marrow is not working very well because of one of these issues. So will I have a lot of reticulocytes? No, they're going to drop. So my reticulocyte index will drop. But we like to use a particular percentage that I want you to remember. It'll actually drop to less than 2%. And that's important. In the other end of the spectrum, what if it's due to an increased loss? I'm bleeding, losing blood, and then my reticulocytes are I'm actually causing my bone marrow to compensate. If it's working, all these things are good, then my bone marrow is going to jack it up and produce tons of red blood cells. It's going to try to. And if that happens, what would happen to the reticulocyte index? It would go up. And so if the reticulocyte index increases, that would be more suggestive of a loss or a destruction problem. If the bone marrow's working and all these things are good, okay, that's the caveat here. And we say technically it's when it's greater than 2%. All right, my friends, that will cover the basic life cycle, and I think it helps us to stratify these two different types, because now what we got to do is we got to figure out anemia. How do we figure out the anemia that's due to decreased production? Well, we got to figure out all these issues, and we're going to talk about that now, what kind of tests and things that we go through, all the algorithmic steps. Then after that, we got to say, okay, how do I figure out which type of issue it is here for the actual destruction loss? And we'll go through all the systematic steps for that and lots of case studies. All right, here we go. So we're going to talk about these types of anemias specifically with the decreased production issue. Now, when we talk about these, one of the big things that you want to think about here, so we know it's a decreased production, so we know it's a problem with hormones, nutrients, drugs, toxins, or intrinsic bone marrow dysfunction, right? That's what we have an idea of. So think about those things under your differential. But before we even start kind of going down that rabbit hole, again, quickly, what is anemia? Because now we're going to start talking about that a little bit. With anemia, it is a low oxygen carrying capacity, right? And usually the best way to define anemia is whenever you have a decrease in your red blood cell mass. And specifically, we say there is a decrease in the hemoglobin, a decrease in the hematocrit, and technically, in some situations, in most cases, there's a decrease in the number of red blood cells. That doesn't always hold true in every single type of anemia. I would say out of these three, these are going to be the most important one. But for the most part, it's usually all of those. If they're low, it's suggestive of anemia. Okay, so we have anemia. Once we determine there's anemia, low hemoglobin, low hematocrit, low red blood cells, then we got to say, okay, is it due to an underproduction or an increased destruction/loss problem? How do I do that? In a perfect world, you can check a reticulocyte index. So you order the reticulocytes, that's a separate order. When you order the reticulocytes, you get the number back, you put it into that reticulocyte index equation, and you spit out a percentage. We said, if the reticulocyte index comes back as less than 2%, it's a decreased production problem. Yeah? And if it comes back at greater than 2% in a perfect world, it's an increase in destruction, like in hemolysis, or it's a increase in loss, such as in bleeding. In patients who are talking about this problem, decrease in production in a perfect world, the reticulocyte index will be less than 2%. Don't forget that. So order your retics, boom, stratify this. Now you have a person who has some type of decreased production problem. And again, this is in a perfect world. That's not always the case in true clinical situations. After you do that, in the CBC, there's something called the MCV, the mean corpuscular volume. Mean corpuscular volume just tells you the size of the red blood cells, and that helps you to determine which type of underproduction type of anemia we have. If the MCV normally it's 80 to 100 femtoliters, and that's in like a generalized number. It can vary all the time, but that's a generalized number. So if the MCV is low, less than 80, we call that a microcytic anemia, okay? So we'll put here on the side a low MCV. If it's actually going to be normal MCV, so it's between 80 to 100, that is a normocytic anemia. And then if it is a high MCV greater than 100 femtoliters, then this is a macrocytic anemia, and that would be the last one that we talk about. So now we have the three types that we're suspicious of, okay? Now we got to say, okay, what kind of tests, what kind of things should I be thinking about for a patient who has a microcytic anemia? Differential, don't forget these. I want you to keep remembering these. Maybe you have to repeat it a couple times. Iron deficiency anemia, anemia of chronic disease, thalassemia, sideroblastic anemia. Okay, again, iron deficiency, sideroblastic, anemia, chronic disease, and thalassemia. Those are your differentials. How do I figure out which one it is? The first thing I think that's actually somewhat beneficial, okay, is to just kind of like write these three out here. So let's write these kind of general, well, actually what I like to do is like to check something called an RDW, but we'll get into all these things. I'm going to talk about in sequence. Usually the way it's easily kind of defined is you check a bunch of different tests. So here's what we're going to do. We're going to check a bunch of different tests. The tests that I will order for these patients is I'll check their RDW, I will check their red blood cells, I will check what's called their Menser's index. I will check iron studies. And then I will also look at what's called a peripheral blood smear. And then I'll also take into consideration their history. But these are the basic things that I'm going to test. All right, once I check all of these things, I can kind of start going into my different types here. So now I'm going to have iron deficiency anemia, okay? So iron deficiency anemia, that one being first. When I think about this one, when I look at the RDW, one of the big things is RDW tells me like the variation in size of the red blood cells. And whenever somebody has iron deficiency anemia, they typically have a high RDW. So that's kind of the first thing that I'll look at, and I get that from my CBC as well. So in iron deficiency anemia, one of the big things is you'll see a patient who has a high RDW. Their red blood cells are typically low, okay? So they have a low number of red blood cells, okay? And obviously with this patient having anemia. The next thing is I'll look at my Menser's index. All the Menser's index is, if I write it up here, all the Menser's index is you're taking the MCV divided by the red blood cell number. And that should give you kind of that Menser's index. And this is helpful in a condition that we're going to talk about in a little bit called thalassemia. The Menser's index in iron deficiency anemia is somewhat helpful, and what I want you to just remember for right now is the Menser's index is greater than 13%. I promise this will make just sense in just a second, but for right now, just remember that. The next thing I'll do is I'll check my iron studies, right? So my iron studies, you get a bunch of different things from the iron studies. What are some of the things that you get from iron studies? From the iron studies, you'll get a couple different things. You'll get what's called iron, obviously. You'll get something called ferritin. You'll get something called the TIBC. And the last thing you'll get is something called a transferrin saturation. Out of all of these, this can get kind of complicated with all these different types of anemias, and I feel like it can be way too much to remember. So you know what I like to do? I like to kind of make it a little bit more simple, and I only utilize this one and this one. I think all the other ones are kind of like a little bit more complicated, and they just kind of like confuse me sometimes. And then I end up trying to remember things and memorize it, and it doesn't really work. So the easy way to look at these is look at the ferritin and look at the transferrin saturation. That's what I kind of look at, and that usually can help me to differentiate what I got here. So in iron studies, what you want to look at is ferritin. Ferritin is kind of like it tells you it's a protein that binds to iron inside of our cells. So it kind of tells us about our iron reserves. Generally, in a perfect world, on your exams, the ferritin is usually low, okay, in a perfect world. That's not always the case, so remember that. But in a perfect world, the ferritin is low. Then the other thing is the transferrin saturation. You know how we actually get transferrin saturation? Transferrin saturation is an equation that utilizes, it takes iron and divides it by the TIBC, okay, divides it by the TIBC. Generally, the TIBC in iron deficiency anemia patients is high. And then usually iron is low. So if you look at this kind of like number here, I guess, it should kind of ding off a relatively obvious thing. You have a low numerator and a high denominator. The overall percentage is going to be low. So you'll have a low percentage. So in these patients, they'll have what's called a low transferrin saturation. And that's really the only time I think this is actually the beneficial component of the iron studies. Other than that, I don't really use the iron studies other than that just for kind of like my iron deficiency anemia. I don't think it's really helpful for that. It may be a little bit helpful in other kind of diseases, but not super great. So that's what I get from there. Peripheral blood smear, it's not super helpful. So I don't actually get a lot from my peripheral blood smear on my iron deficiency anemia. All right, boom. Next one, what did we say? We have iron deficiency anemia, then what else did we say? We said anemia of chronic disease. So anemia of chronic disease. When I look at this one, I can look at the RDW. The RDW actually doesn't really help me. It's usually like relatively normal. So that's not a super beneficial thing. My red blood cells are usually low. My Menser index doesn't actually really help me, so I'm gonna get rid of that part. One of the things I do think is somewhat beneficial in a perfect world for anemia of chronic disease from the iron studies is that their actual ferritin levels tend to be relatively high. So that is one thing I would actually take a look at. And the reason why, in the most basic concept, is when someone has an anemia of like a chronic disease, it's usually an inflammatory disease. And the liver The ferritin is actually an acute phase reactant protein, so it's released whenever there's lots of inflammation. And in anemia of a chronic disease due to inflammation, it's going to cause the liver to make a lot of ferritin. So ferritin levels tend to be high. The transferrin saturation, the TIBC, all that stuff, that can be variable, so I don't really want to get too much into that. Just look at the ferritin, but the big thing is their history. That's what really cues you off in this one. The labs aren't super helpful. It's more their history that leads you off to it. Sometimes what you can do whenever people are confused between this one and this one, you can check like a soluble transferrin receptor. Sometimes that's helpful. I don't actually think it's usually necessary, and it's usually an expensive test. I wouldn't worry too much about that one. Okay, I think that's the big thing. Peripheral blood smear, also relatively unrevealing. Big thing here, I think that's key here, is looking at your history. That is like the huge component here that you have to look at. And usually it's kind of like an exclusionary component. All right, the next one here we said is thalassemia. So thalassemia is a really interesting one. So what I would do is I check the RDW. The RDW can actually be somewhat high, but it can also be normal. So I don't really think it's super beneficial in this condition, to be honest with you. What I do think is actually helpful here is, you know what, classically the red blood cells tend to be relatively normal. So that's an important component to remember. The red blood cells tend to be normal. Now this is where that Menser index actually comes in handy. The Menser index is really good for this one. This is what I want you to remember for thalassemia, especially in these cases, is we said the Menser index is the MCV divided by the red blood cell. In thalassemia, these patients' MCVs are super low. What I want you to remember, I want to put it down in just a second, but their MCVs are typically less than 70. So if you see an MCV less than 70 and a Menser index less than 13%, be potentially thinking about thalassemia, especially if they have history. Okay, so from there, I want you to remember that they'll have a super low MCV and their red blood cells are normal. So they'll have a super low numerator, and therefore their overall number will be really low. So their Menser index, they'll put their Menser index, is going to be less than 13%. So really important thing to remember there, okay? Next thing is my iron studies. They're usually not very helpful, okay, because they can be like relatively normal. So they're not very helpful for the iron studies. I wouldn't worry about those too much. The peripheral blood smear can actually be somewhat helpful. So for these patients, the peripheral blood smear may show something called basophilic stippling. And so that's not pathognomonic for a thalassemia, but it's something that if you see in the clinical vignette where you have a patient who has a very low Menser index, they also have basophilic stippling, and they have a history. That's the key thing. Look at their history. I want to add that on here, plus history. I'm going to put HX there. History, that's another key component that you need in their workup. And they have history, so in other words, they have a positive family history. Maybe their family history, they have like a person who has thalassemia, or they have like a Mediterranean ancestry, they immigrated from somewhere. Look about that in the clinical vignette. However, the most important thing that we did not add, but I'm just going to add it on usually as a specific diagnostic tool, if you see these things, a really low Mensers, high RDW to normal RDW, not very helpful. You see some basophilic stippling, you have history, you're concerned for it, you can confirm and get what's called a hemoglobin electrophoresis. And this will usually clinch your diagnosis for actually having somebody who has potentially a thalassemia, okay? All right, the last one here within these is going to be sideroblastic anemia. So sideroblastic anemia is basically a problem where you aren't able to use the iron that you actually have because they're kind of like stored within inside of your red blood cells. They're kind of just locked within them, okay? And this is usually due to medications and drugs, all right? This one is usually a genetic defect of a globin chain, so an alpha chain or a beta chain. This one's usually due to a lot of inflammatory diseases, and this one's due to a deficiency in iron, right? So it's pretty straightforward. But in this situation with sideroblastic anemia, when you check their RDW, it tends to be high, so that may help you. So you can already say, I would say the big ones to remember is sideroblastic iron deficiency for the RDW. Not very helpful for these two. Next thing for the sideroblastic is your RBCs. They are usually low. Next thing is check your iron studies. Are they going to be helpful? Not necessarily. To be honest with you, they don't really give you a ton of information, so I wouldn't really look at those too much to really kind of determine which one these are. Peripheral blood smear is where I think it's going to be the key component in helping you to determine this. So what I would look at in the peripheral blood smear is you can get two types of things. You can sometimes see, again, just like you saw over here with thalassemia, basophilic stippling. That's why it's not always like the case that, oh, basophilic stippling is thalassemia. No, you can see this in a bunch of other diseases. What I think is important though for the basophilic stippling is one of the causes of sideroblastic anemia is lead poisoning. And so if you see in the case like a patient who's like a little child and was like exposed to paint or something like that, check a lead level and see if that's elevated, especially if you see basophilic stippling and signs of sideroblastic anemia. But I think one of the telltale signs and the giveaways in your actual exam is they'll maybe show you a blood smear, and I'm going to show you guys some case examples, but they'll show you a blood smear and it'll show something called sideroblasts. And this is basically these cells that have like these like bluish dots all within them, and it's all the iron that's just accumulated within inside of the actual cell. And so that's one of the big things if you see sideroblasts. Sometimes they even have what's called Pappenheimer bodies. Don't worry about that. I think sideroblasts is the big thing. What you need to do though is if you see sideroblasts, you need to get a bone marrow biopsy to confirm. That's the only way that you can truly like confirm sideroblastic anemia is if you see the sideroblasts on peripheral blood smear, you need the bone marrow biopsy to confirm. This is the way that I would go about these types of conditions. And again, history. Usually for the history here, for the history, look at medications. So exposure to lead, lots of alcohol use, certain medications that can trigger this. There's lots of medications for sideroblastic anemia. But again, these are the things to think about here in your differential. All right, we covered your microcytics. We'll do some case examples in just a little bit to see if we can test your knowledge. But let's move on to normocytic anemias. So for normocytic anemia, we said it has to be within the 80 to 100 femtoliters. So we're within the range. We're now within the range of someone having 80 to 100 femtoliters for their MCV. So with normocytic anemia, what is the differential here? Okay, it's a little odd, but with these patients, what you actually want to do first is sometimes in patients who have what's called iron deficiency anemia, you're like, wait, Zach, you just said it was for microcytic. Yes. And patients who have early iron deficiency anemia, they can actually have a normocytic anemia. So what I do for these patients for normocytic anemia, the first thing I'll do is I will check an iron level. I will actually check iron studies. And the iron studies will be helpful because what they'll help me to do is see if I have an iron deficiency anemia. And I can still use all of these kind of tools here. But I'll check my iron studies. The next thing I'll do is I'll check for a B12 level. I'll check a folate level because sometimes early B12 deficiency and folate deficiency can also cause a normocytic anemia. You'll see here in a little bit that B12 and folate usually cause macrocytic anemia, but if it's early, it can actually cause this first. Just like iron deficiency anemia normally causes a microcytic. But in the early stages of iron deficiency, it can cause a normocytic, okay? I'll check these things. After I do the iron studies, the B12, the folate, the next thing I'll do is I'll check potentially some other organs to see if they're a little jacked up. So the ones I'll look for is I'll check my thyroid function, because that was one of the organs there. So I'll check my TFTs. I'll also look at liver function, so I'll look at LFTs. And I'll also look at kidney function, so I can look at a BMP, okay? And again, look at their history. Obviously, if they have like a end-stage or chronic kidney disease, that could be potentially obvious, okay? And then we'll talk about something else that's really important here in just a second. And these patients that also have, I've gone through these and I've looked to see if they have any liver, any kidney disease, any type of thyroid disease, and all of that's relatively normal. The other thing I can consider potentially is there any hemolysis? But we'll talk about that a little bit more later in the actual increase in destruction loss. So you're probably like, wait, Zach, I thought hemolysis, that's always going to be a retic index greater than 2%. You said that if it's less than 2%, it can't be hemolysis. That's not necessarily the case. And here's why. It's a little caveat. In the boards, it will be like that. It'll likely be retic index greater than 2%, it's hemolysis. In an actual clinical situation, sometimes people can have an underlying like bone marrow disorder where they're not actually producing an adequate number of red blood cells. Let's say they have iron deficiency anemia. And then all of a sudden they develop a hemolytic anemia on top of their underlying iron deficiency anemia. Well, they're actually going to have destruction of red blood cells that'll try to tell the bone marrow to make more red blood cells, but guess what? The bone marrow is not working well because they have iron deficiency anemia. And so the production of reticulocytes will still be low. And so that's why sometimes you can still have hemolysis in a normocytic anemia. I'm going to put it in there, but remember, we're going to talk about it more in this actual increase in destruction loss process. So put hemolytic labs, you'll also order that as well. The last thing that you consider in these patients is what's called a bone marrow biopsy. And again, we'll talk about that. Okay, so when you go through these are the things that you want to check, okay? You check your iron studies. If you check your iron studies, let's say, and you obviously have this super obvious, let's say that you check the iron studies and you think that they have iron deficiency anemia, what would you look for? You would see that they would potentially have a very low ferritin, and they would have a low transferrin saturation. That's a pretty obvious thing there, okay? You know what else is really interesting? For the iron studies, not only do they help you to determine if you have iron deficiency anemia, okay, so these can help you with iron deficiency anemia, they can also say, is there any anemia of chronic disease? You're probably like, Zach, you just said anemia of chronic disease can be a microcytic anemia. It can, but it can also be a normocytic anemia. And again, it depends upon the history. So you gotta look at the history. Do they have RA? Do they have SLE? Do they have a malignancy? Do they have chronic kidney disease? Check those things. But if they have anemia of chronic disease, what I tell you would happen with that ferritin? It's usually pretty high. Again, that's not always perfect, but it can help you somewhat, okay? And again, with these patients, both of them can have low iron, okay? And their transferrin saturation for anemia of chronic disease, it can also vary a lot. But again, something to think about. Then for the B12 and folate, you want to see if the B12 and folate is low. So if the B12 is low, okay, we got B12 deficiency. If the folate is low, which is also known as B9, then it's folate deficiency. But sometimes you can get a little tweener, okay? Sometimes if it's not this one or this one, you get a weird situation where you have what's called a borderline low B12 and folate, where it's just at the end up like the lower limit of normal. If that's the case, what you order here is you order something called a methylmalonic acid, and you order something called a homocysteine level. In these situations, if it's borderline low and you're not sure which one it is, if it's true B12 deficiency, the methylmalonic acid will be elevated and the homocysteine will be elevated. If it's a B9 or folate deficiency, the methylmalonic acid will be normal and their homocysteine levels will be elevated. Okay, so that's an important thing to remember. So we check our iron studies, we check our B12 and folate for early iron deficiency anemia, early B12 folate deficiency anemia, also consider anemia of chronic disease. But what I tell you is really important here, history, my friends, that's the most important component here. Check your TFTs. If you have low T3, low T4, what do you think it is? Hypothyroidism. Oh man, you're good. What if you have increasing LFTs? Increase AST, increase ALT, increase other different types of liver enzymes, maybe a drop in their albumin, an increase in their INR. It could be liver failure related. That's important. If it's BMP, do they have an increase in their BUN? Do they have an increase in their creatinine? It could be CKD. So they may have chronic kidney disease. Sometimes, I don't suggest it, but sometimes the literature will say, if they have CKD, check like an EPO level. And remember, erythropoietin was the driver for red blood cell production. If the kidneys are failing, can they make EPO? No. So what would you think the EPO levels would be? Low. So sometimes you can do that. Sometimes they suggest not necessarily doing that. Hemolytic labs, we're gonna talk about this more in destruction and loss. You still wanna check them because you can have this, believe it or not. We're not gonna go through it now. I'm gonna put just C above. We're gonna talk about that a little bit later. Okay, the next thing that you also wanna consider for these patients here is, would I ever get a bone marrow biopsy? Why would I ever do a bone marrow biopsy? Remember I told you that if it's a problem, it's a nutritional, it's a hormonal, it's a drug, or it's an intrinsic bone marrow issue. Normocytic anemias typically tend to be bone marrow issues if you think about these ones. Usually if it's an intrinsic bone marrow problem, it's likely normocytic. So here's what would cue you up to say, ooh, shoot, this could be an intrinsic bone marrow problem. I would consider a bone marrow biopsy, and this is where I'm telling you, please listen here. If my reticulocyte index is like super low, like non-existent, I'm talking like 0.1%. So it's less than 2, but it's like almost 0. If that's the case, like 0.1%, that's a concerning sign. Another thing is, what if they also have what's called pancytopenia? Do you guys know what that is? I know you know what it is. Low red blood cells, low platelets, and low white cells. All the cell lines are dropped. If that's the case, something is wrong with the bone marrow. If I am basically making no red blood cells, no reticulocytes, that's super concerning for a bone marrow problem. And if other cells are being affected, that's super concerning for a bone marrow problem. Biopsy the bone marrow, and sometimes what this can show you is 3 particular types of conditions. One is called aplastic anemia. In this situation, if you check their bone marrow biopsy, they make no cells. All their cell lines are dropped. And so what you would see is, we're gonna just kind of look here, low proliferative bone marrow biopsy. You can check for something called MDS, myelodysplastic syndrome. In this situation, they're producing lots of blast cells that don't actually have any room to allow for any red blood cells, platelets, or white blood cells to be produced. And so they crowd out the bone marrow, but you're still having low levels of all these cell lines and low retics. So again, an aplastic, low retics, and pancytopenia. MDS, low retics, and pancytopenia. But if you look at the difference here, they have a hyperproliferative bone marrow filled with lots of blast cells, immature cells. The last one is the most rare one and weird one, called pure red cell aplasia. And this, there is no pancytopenia. So here, let's do this. None of that. Only in super obvious low reticulocyte count, you get a bone marrow biopsy and you check, and they have low erythroblasts. So their red cell line is the only one that's just pretty much stinks. If that's the case, it could be suggestive of pure red cell aplasia. A lot of things to think about with this one. I promise, I know it seems like a lot, but we're gonna do some practice problems to make sense of it. But these are the things that I want you guys to be thinking about when you're having a patient who comes up with a normocytic anemia. Let's hit it home with macrocytic. All right, macrocytic anemia. So we checked our MCV, and it is greater than 100 femtoliters, right? So we got some big honking cells. So high MCV, greater than 100 femtoliters, okay? When we do this one, we got to think about our differentials for this one. All right, so the way I think about the differentials is, again, I think about the test that I need to order. It just helps me to categorize it in my brain. So for macrocytic anemias, I want to check. I would like to check, first off, a B12, a folate level. Then after I do that, I like to look, and since I'm ordering labs, I might as well just add some other labs. So I'll add in some thyroid function tests. I'll add in some LFTs. I'll look at their meds, and I'll also check a blood alcohol concentration if they're not telling me the truth about their alcohol history. After I do that, I also consider some other particular things. Maybe like a peripheral blood smear also can be somewhat helpful. Lastly, I usually don't actually get to this point where I think it's absolutely necessary unless there's something super concerning. But you can sometimes consider a bone marrow biopsy. I would put plus or minus there, and kind of remember, it's easier to remember for normocytic, but you can potentially have some bone marrow problems with macrocytic anemia. All right, but this is kind of like the cut and dry way that I go about ordering these tests. So first thing is, I got the B12 and folate. Why? Because B12 and folate deficiency, it's easiest to remember that they're macrocytic, but don't forget that they can cause in their early diseases, normocytic. Just like iron deficiency is microcytic. In the early diseases, it can cause normocytic. When I check the B12 and folate, this is gonna be a reminder, guys. What did I say? You check the B12 level, it's low, you're diagnostic. If you check the folate, which is also known as B9, it's low, it's diagnostic. But if I have a patient who has borderline, it's just on that lower limit of normal of their B9, their folate, and their B12, and I don't know which one it is, what can I do? I can obviously look at their history, but I can check for the B12 deficiency. Typically, I look at the methyl malonic acid, and the homocysteine levels. And then same thing for B9 or folate deficiency, I look at the methylmalonic acid and the homocysteine levels. In a perfect world, this for B12 is elevated for both of them, and for B9, the MMA is normal and the homocysteine is elevated. Okay? Boom, I figured that one out. For the thyroid function test, I'm looking for a low T3 and a low T4. For my LFTs, I'm looking for increases in LFTs. And remember, this could have a patient who has also a history. Look at their history. Sometimes you don't even need these tests. You can actually look at their history and they have diagnosis of hypothyroidism, and maybe they're not taking their meds or they're not on a proper dose. They have a history of cirrhosis, right? Something of that nature, and they continue to do things that they're not supposed to be doing, worsening their disease. Look at their medications. And so when you look at their medications, there are so many different medications. I think sometimes on the boards, they will actually try to have you remember certain ones. And so the things I would potentially consider here is some of the meds, like you're kind of like the chemo, is somewhat of the chemotherapy or things where they impair DNA synthesis or replication. Methotrexate is definitely one of them. Another one called 5-fluorouracil. Another one called hydroxyurea is a big one that you can utilize in a patient who has a sickle cell anemia. Other ones are any kind of like HIV meds, but more specifically like the protease inhibitors like zidovudine. Another one here would be like antibiotics. The specific antibiotics I would remember here is what's called trimethoprim sulfamethoxazole, also known as Bactrim. Another one is your anti-seizure meds. And so your anti-seizure meds like phenytoin and valproic acid are really big ones as well. Here's the big mama though. If they have a history that's positive for alcohol use, heavy alcohol use, that could be also a very important medication to be thinking about as well. If maybe you're uncertain, there's questions that they're actually not telling the truth, you can look for an elevated blood alcohol concentration to verify that maybe they are a heavy drinker and they just drank recently or something of that nature. Okay? These could be somewhat helpful in your diagnosis. Now the peripheral blood smear, so what you can actually do is, some of the actual literature will actually say you should order this first to really determine how you're going to test somebody, which can somewhat be helpful in stratifying. You can remember this, I would say just in general, remember this one component of it. From the peripheral blood smear, when you get a peripheral blood smear, you want to determine if they have what's called megaloblastic macrocytic anemia or non-megaloblastic macrocytic anemia. And so the way you do that is you get a peripheral blood smear and you look to see if they have what's called megaloblast. So megaloblast is basically you're looking at the neutrophils. And when you look at the neutrophils, usually they have like a couple lobes, like 3 lobes generally, normally. But in these patients who have a macrocytic anemia, which have megaloblasts, usually it's B12 folate deficiency, some types of medications or alcohol. They can impair the DNA synthesis in the maturation process, and they can cause like multiple lobes. So if they got greater than like 5 lobes, we sometimes call these I'm gonna abbreviate it, hyper-segmented neutrophils. That's megaloblastic. And you should have a high degree of suspicion for B12 folate deficiency or some type of medication, or maybe even like alcoholism. Those would be big things to think about, and it would make it easier what tests you can kind of order and which ones maybe you don't have to get right now. So that's one of the big things is it positive for megaloblast or is it non-megaloblast? And megaloblastic macrocytic anemia. In other words, they do not have this above issue there. So in other words, they don't have greater than 5-lobed polymorphonuclear leukocytes or neutrophils. So they don't have hypersegmented neutrophils. So in these situations, they are negative for hypersegmented neutrophils. More likely suggesting like a thyroid issue, a liver issue, or maybe some type of underlying bone marrow problem. Okay, and sometimes even drugs and medications as well. The bone marrow biopsy, my friends, I would caution to potentially not always be right up front with this one. I think if you have a patient who you see potentially like pancytopenia, so you have any concerns and they have pancytopenia, low red cells, low white cells, low platelets, it might not be a bad idea to potentially get a bone marrow biopsy, because this may tell you if you have something called myelodysplastic syndrome. And with myelodysplastic syndrome, they would have pancytopenia. And again, if you looked at that bone marrow biopsy, what do we say would happen? You'd have a high proliferative type of bone marrow with tons of blasts crowding out the actual bone marrow and not allowing for red cells and white cells and platelets to be produced adequately. And so that could actually also cause a macrocytic anemia. Sometimes they even say multiple myeloma, but I would kind of just keep it simple with these. And if you really have the extra brain space, maybe consider this one. But these are the things that I want you to remember for your workup and how to systematically approach your different types of anemias due to a decreased production issue. So what we can do now is we can actually take a look at a bunch of case studies, practice, do some spaced repetition to see if all of this stuff makes sense and if you're able to solve some problems and give you guys some confidence when you see these CBCs and you have to interpret it. So let's get to it. All right, so let's go through our case studies, guys, and really put to practice everything that we just talked about on the board, because it was a lot, and I want to make sure that you guys feel comfortable with this. All right, so first case. This is going to put to practice everything we talked about. Keep that systematic approach. Ready? 26-year-old female, past medical history, heavy menstrual periods, hemoglobin 9.6. She's anemic. We got to determine if it's a decreased production or increased destruction/loss. How do we do that? Retic index. If retic index is less than 2, it's underproduction. If it's greater than 2, it's increased destruction loss. Let's see what it is. It's less than 2, underproduction. From an underproduction point, you have to then check the MCV to see what kind of cytic it is, normal, micro, or macro. We check the MCV. It's actually 75. That's less than normal. So it's a microcytic anemia. If it's a microcytic, what's the differential? Iron deficiency anemia, thalassemia, sideroblastic, and anemia chronic disease. After we do that, we check our RDW, our red blood cells, and sometimes you can calculate a Mincer's index. Boom, RDW is high. That's potentially suggestive of iron deficiency anemia, but you can also see this in sideroblastic anemia. Red blood cells are low, and the Mincer index is 15. That kind of tells me that it's unlikely thalassemia, since thalassemia is usually less than 13%. Okay, next part is I check my iron studies. Ferritin's low. Whoa, what did I say when ferritin's low? Automatically have a high degree of suspicion in a perfect world that it's iron deficiency anemia. And then the transferrin saturation is also low. How do you calculate that? You take the iron divided by the TIBC. Iron's low, usually an iron deficiency anemia, and TIBC is usually high. So that's why you should have a low transferrin saturation. Very, very likely that this is basically an iron deficiency anemia, and usually the peripheral blood smear, which is the last test that we can get, is usually unrevealing. It's not telling me very much. I think this is iron deficiency with very strong confidence. Okay, move on to the next one. Case 2. We got an 85-year-old female, history of SLE, presents with hemoglobin of 10.2. She's anemic. Check the retic index. It's less than 2, underproduction. So now we got to check the MCV. MCV is 75. That tells me that it's a microcytic. It's one of those 4. What do I do? Again, I got to check my RDW, my red blood cells, and sometimes my Mincer index. I check my RDW, it's normal. Unlikely iron deficiency anemia, unlikely sideroblastic anemia. Could be potentially what? Anemia, chronic disease, or thalassemia. Red blood cells are low. Usually they're normal in thalassemia. Let's pretend that I put the Mincer's index in here. In this patient, the Mincer's index is actually 16%, let's just say. So it's unlikely thalassemia. So we're kind of potentially thinking this could be anemia, chronic disease. Plus, what did I tell you to do after this? Get your iron studies. Iron studies, ferritin's high. What did I tell you was one disease I think is actually relatively important to remember, that ferritin can be very, very high, especially if there's a chronic disease, anemia, chronic disease. So ferritin's pretty high, and plus this person has a medical disease that would actually put them at risk of having a lot of inflammation to cause that ferritin to go up. Okay, next thing I could do is a peripheral blood smear. Is it going to help me with anemia, chronic disease that I have a high suspicion of? No. So therefore, I think that this is anemia, chronic disease, because it fits well with the presentation, history, and the labs. Okay, next one. 3. Past medical history of a guy who has TB exposure, got treated with isoniazid. He's got a hemoglobin of 8.9. He's anemic. What do we do? Check retic. What's the retic? Less than 2. Underproduction. Check the MCV. If the MCV is there, what do we think? This is a microcytic. If it's a microcytic, it's one of those 4. What do we always do? RDW, red blood cells, Mincer's. And this person, the RDW is high, potentially iron deficiency or sideroblastic. Red blood cells are low. Let's just tell you that the Mincer is, again, greater than 13%. Unlikely thalassemia, unlikely iron deficiency. I mean, it could be iron deficiency anemia. It could be sideroblastic anemia. We don't really have a strong understanding if it's anemia, chronic disease just yet. What do we do? Iron studies. They're normal. that kind of tells me that it's not iron deficiency anemia, and it also tells me that it's not likely that this person has anemia of chronic disease. But again, there's nothing like super special about this. What's the next thing I need? Peripheral blood smear. Look at the peripheral blood smear, guys. What do you see these things? Ooh, those are your sideroblasts. This is a slide that you definitely have to be able to recognize. If it's sideroblasts, we have to confirm with a bone marrow biopsy, but this would tell me that this is sideroblastic anemia. And you guys are on a roll. All right, here we go. Case study 4. 34-year-old female with Mediterranean ancestry who has been treated with iron supplementation for a while and still has a hemoglobin of 9.5 despite that. What do we do? Retic index, it's less than 2, under production. MCV, 65. Oh, what I tell you to remember if you've seen MCV less than 70 to have a high degree of suspicion for? Thalassemia. Check the RDW, check the red cells, check the Mensers. RDW is normal. It kind of tells me that's unlikely iron deficiency and sideroblastic potentially. Red blood cells are normal. That also made me think about thalassemia. And the Mensers is less than 13%. That makes me think about thalassemia. What do? Iron studies. They're unrevealing. Again, not very helpful for the thalassemia patient. Usually they're relatively normal. Peripheral blood smear, what can we see? Sometimes you can see basophilic stippling in these patients. You guys see like there's like these actual like little blue dots around these like red blood cells here. Some of them have some basophilic stippling, and like in this one here as well. And in this one here, that would be potentially something to think about that you could see in a person who has thalassemia, but it's not pathognomonic. Well, we definitely need to completely diagnose it. Well, we need history. They have a Mediterranean history. That's a possibility. I would need a hemoglobin electrophoresis. I get it, and it's positive. What's my diagnosis? Thalassemia. All right, 5. We have a 54-year-old female, past medical history of seizures, treated with fosphenytoin, and had a recent UTI. She was treated with Bactrim, which is trimethylprednisolone, and she comes in with a hemoglobin of 8.6. She's anemic. All right, what do? Check the retic. It's less than 2, under production. We check the MCV to determine if it's micro, normal, or macro. Oh, that's macro. Macrocytic, what do we think? Okay, we always should check a B12. We should check a folate. We should look at their meds, look at their alcohol, look at their TSH, look at their thyroid functions, look at their LFTs, and then if we're super concerned, we can also do a peripheral blood smear. Lastly, we can consider a bone marrow biopsy. We're going to do these in order, right? All right, so what do? Check the B12 and folate first. They're normal. Kind of rules out that they have B12 and folate deficiency. What will be the other ones? Look at their medications, look at the alcohol, look at the thyroid functions, the liver functions. Let's do all that. TFTs are normal. LFTs are normal. Blood alcohol concentration is normal, and they have no history of alcoholism. Okay, what else do I got to look at? Look at the meds. I look at the meds. Is there any one of these meds that concern you? Do you guys see anything? Bactrim, trimethylprednisolone, and then this is actually fosphenytoin. It's one of the actual brothers or cousins, you can say, of phenytoin. So there's a possibility that these two drugs could have possibly done what? They could have actually caused this anemia. And then again, we look to see the actual peripheral blood smear. Sometimes it can be helpful, sometimes not. Again, you can get that peripheral blood smear to see if you see any hypersegmented neutrophils suggestive of megaloblastic anemia. What did I say? In the perfect world, megaloblastic anemia suggests if it's present, greater than 5 polymorphonucleocytes or white neutrophils. It's usually suggestive of B12 or folate deficiency in a perfect world. But it's not actually present here, so it makes you think about all the other causes like thyroid, liver, medications, alcohol, stuff of that nature. So again, likely medication-related cause for this patient's anemia, a macrocytic type. All right, here we go. Next one. Case 6. 75-year-old male, past medical history of cirrhosis, secondary to non-alcoholic fatty liver disease, presents with a hemoglobin of 10.1. He's anemic. What do? Check the retic. It's low, under production. What do? Check MCV. It's high. Macrocytic. What do I got to do? B12, folate, TFTs, LFTs, medication, alcohol, peripheral blood smear. Folate, B12 normal, TFTs normal. Oh, elevated LFTs, and they have a history of cirrhosis. And there was no particular meds in their actual history that was a potential culprit, and they don't drink, and there is no history of it, and their blood alcohol concentration is normal. Okay, so I definitely have a likely culprit here, that being the cirrhosis. We should be consistent, though. What do we say to check after this? Peripheral blood smear. We look at the peripheral blood smear. I didn't tell you guys this on the whiteboard, but I'm going to tell you it now. Sometimes with liver disease, you can actually get these special types of like little like PC kind of weird looking cells here called acanthocytes. So these are called acanthocytes, and you can kind of see these in patients who have liver disease. It's not absolutely like, oh, you only see it in this disease, but it's somewhat suggestive of it. So that's something to think about there. And again, they have no hypersegmented neutrophils, so that would unlikely be a megaloblastic anemia. It's likely a non-megaloblastic. All right, so it's likely a liver disease-related anemia. All right, great job. 7. All right, here we go. 54-year-old female, past medical history, CKD4, presents with hemoglobin of 8.6, anemic. What do you do? Check retic. It's low, under production. What do you do? Check MCV. It's low. MCV is 85. MCV is normal. I apologize, 80 to 100. So that's a normocytic anemia. You would also want to do what with these? Again, look at your red blood cells. They're low. What do we do for our normocytic anemias? What did I tell you to always check? Could be early iron deficiency, could be early folate and B12 deficiency. Then after that, you also want to check your kidney, your liver, and you also want to check the thyroid function. And then after that, you want to check your hemolytic labs if you're absolutely concerned for that. But in a perfect world, we're probably not going to do that right now, because we're going to keep it perfect as whenever hemolysis is something I'm concerned about when the retic is greater than 2. So we're not going to check those. And then what did we say was last if we have high concerns of it? A bone marrow biopsy possibly, right? All right, so let's go through here. So first thing that we should be checking is, again, iron and B12 folate. So we check all of those things. We check the iron studies. The ferritin is high. Is ferritin usually high in iron deficiency anemia in a perfect world? No. It's usually low. So the ferritin's high. That means that there's likely some type of anemia of chronic disease here. What's this? CKD. That's one of the diseases. All right. Transferrin Sach is normal. Folate, B12 normal. Thyroid function is normal. LFT is normal. No obvious meds in their medical history. But they do have a history of chronic kidney disease. That's interesting. Okay. What else do I check? Do I need to do any kind of like bone marrow biopsy? No. The peripheral blood smear doesn't really show me anything. It's likely anemia of chronic disease. Why? Because again, ferritin's high, transferrin that's normal, all the folate, B12, iron didn't suggest any iron deficiency anemia, no thyroid abnormalities, no LFT abnormalities. They did have chronic kidney disease, right? CKD was one of those. And CKD can actually be a chronic disease that can actually cause anemia of chronic disease. We actually call it anemia of chronic kidney disease. And so that's likely the problem here. Okay, if we got like a BMP, we'd be able to have evidence that they would have an elevated, potentially BUN or creatinine or some type of decrease in their GFR. All right. All right, case study 8. We got a 75-year-old male, status post-chemo radiation for lung cancer, presents with pancytopenia. What does that mean? Low platelets, low red cells, low white cells. Hemoglobin 7.3. They're anemic. What do? Check a retic. Retic is less than 2. We actually get it, and it's 0.2%. It's barely there. Whew, that's interesting. Okay, well, whenever we have a normocytic anemia, what do we always have to check? We got to make sure it's not early iron deficiency, B12 folate deficiency, make sure there's no thyroid abnormalities, no liver abnormalities. So we got to go through all of that stuff first. And well, actually, before we even do that, forgive me, I went outside of my systematic approach. Again, once you have a retic index less than 2, it's pretty much very, very bad. What do we always do? Again, we under production, check an MCV, normocytic, microcytic, macrocytic. In this case, it's normocytic. Now we know it's normocytic. If it's normocytic, we have to confirm that it's actually either early iron deficiency, B12 folate deficiency, rule out thyroid, liver, kidney disease, and then also potentially a bone marrow problem. So how do we do that? Let's check those labs sequentially. What are we going to do? Iron studies, normal. Folate, B12, normal. TFTs, the thyroid function, normal. CMP, which tells me my liver function and my kidney function, normal. What I tell you was a concerning finding, my friends. If you see pancytopenia and a crazy low retic count, you gotta be concerned about an intrinsic bone marrow problem. So what do I really need to do here? I probably need to get a bone marrow biopsy. And I get a bone marrow biopsy, I look at this, and I see a decreased cellular picture, a low proliferative picture filled with fat tissue. If it's decreased proliferative area with a lot of fat tissue deposition, that is aplastic anemia. And usually aplastic anemia is they have a high EPO. I don't think that's really worth remembering. That's just an extra thing in case you want to remember it. All right, so let's move into this part now. So when we have somebody who has increased destruction / loss of their red blood cells, again, we think that they have anemia, right? So we're kind of starting off that whole anemia part. They have a low hemoglobin, they have a low hematocrit, they have potentially a low number of red blood cells. We try to kind of stratify which type they have. So we check a reticulocyte index. In a perfect world, the reticulocyte index would be greater than 2%, right? So we know that in these patients, they would have a reticulocyte index greater than 2%. And the reason why we would say in a perfect world is because we're saying that the red bone marrow is blasting out red blood cells because there is a drop in red blood cells because you're either losing them or destroying them. But in order to truly have a retic index greater than 2%, you got to have an actual functioning bone marrow. So that's why I say in a perfect world, in your clinical vignettes, your cases that you'll get on your boards, it's going to be perfect. All right, so you have a patient who has a retic index greater than 2%. So now you know it's either an increase in destruction or a loss. How do I figure out if it's a destruction issue? And if when I figure out it's a destruction issue, how do I get to the actual underlying problem here? Because again, you got to remember, we are taking an approach. This is a diagnostic approach to these. We're going to have an individual video on microcytic, macrocytic, normocytic, and hemolytic anemias where we go into detail of all these things. But I want to introduce you to it so you have an approach to these, a basic understanding, so it'll really help you when we talk about these in detail. So with hemolytic anemias, let's start with that, the destruction portion. So when I talk about hemolytic anemias, remember I told you that you could break down the actual red blood cell. When you break it down, you can break it down inside of the vasculature, intravascular, or you can break it down inside of the splenic macrophages, inside the spleen, extravascular. Either way, when you break down red blood cells, inside of the red blood cells, you break down a very specific, there's a lot of different things that can leak out of these red blood cells. So let's say that I break down these red blood cells. When I break them down, I can release out a couple different molecules that you have to check. This is a part of those hemolytic labs that I mentioned in the normocytic anemia. First one that is usually released into the bloodstream because it's released from the red blood cell is LDH, lactate dehydrogenase. That's usually elevated. So it's an enzyme found inside the red blood cell. When you pop it open, leaks out. The other one that also can kind of leak out is bilirubin. So you know, inside of the red blood cells, you have hemoglobin. Hemoglobin has a protein component, and then it also has the heme component. The heme component can get broken down into bilirubin. What is really important though, we're going to call it bili to tell you it's bilirubin, but you know there's two different types of bilirubin, unconjugated, also known as indirect. Just so you know, they can be used two different ways. Indirect bilirubin, I'll put in parentheses though, unconjugated bilirubin is another way of explaining it. This will be elevated in these patients. So they may have some jaundice-like appearance and an increase in bilirubin, but it's more the unconjugated or indirect one. Okay. The next thing that you release out here is you also release out the hemoglobin in general. So whenever hemoglobin gets released into the bloodstream, we don't want it to be by itself. It's a nasty little molecule. And whenever you release this hemoglobin, it's in the vasculature on its own, our beautiful liver says, oh crap, there's lots of this hemoglobin out there, guys, I gotta fix this. And it makes a particular protein, and this protein is called haptoglobin. So haptoglobin, imagine, I'm gonna kind of draw him as like a little circle here, and then imagine hemoglobin, I'm gonna draw him as this circle here. What happens is haptoglobin will not allow hemoglobin to float around by itself. And so hemoglobin and haptoglobin will complex with one another and bind to one another so that haptoglobin can kind of bind to hemoglobin and prevent hemoglobin from causing all types of problems. So there's the complex. Now when the liver makes this haptoglobin and the haptoglobin's binding to the actual hemoglobin, what happens to the free haptoglobin now that it's complexed? You're making a ton of this, a ton of these complexes. What happens to the free haptoglobin? That drops because you're complexing it with all this hemoglobin that's leaking out. So you'll have low haptoglobin. The other thing is some of this hemoglobin actually gets into the urine and actually gets to your kidneys. And when it gets to your kidneys, you can actually pee out some of that hemoglobin into the urine. And so the hemoglobin inside of your urine will also be elevated. And so you'll have what's called an increase in the hemoglobin in the urine. Sometimes we call this hemoglobinuria. Hemoglobinuria. So one of the obvious things that you can test for in a patient who you're concerned, you check they have low hematocrit, low hemoglobin, low red blood cells, retic index greater than 2%, check your hemolytic labs. What are those labs? LDH, indirect bilirubin, haptoglobin, and you can also order a UA and look for hemoglobin in the urine. If you really want to boil this down to the most common two types, it's going to be this one and this one. These are going to be the biggest ones that you'll probably see in your clinical vignette. So you'll check an LDH and a haptoglobin, and that will be the big thing for your hemolysis. If it comes back positive, you have an elevated LDH and a low haptoglobin, you can actually say with some relative confidence there is hemolysis. Now, technically, if it's inside of the vasculature, intravascular, it'll be crazy high. If it's inside of the splenic macrophages, it'll be high, but not significantly. So what you also want to consider sometimes is you want to take into consideration what's their spleen looking like in some of these patients. So maybe they do have some positive hemolytic labs. Take a look at their spleen. And sometimes what I like to just say is look to see if they have any splenic diseases or any kind of liver disease, and then you should consider a splenic ultrasound, because a splenic ultrasound may show you something called splenomegaly. And this is a pretty important thing because splenomegaly may mean that the spleen, so sometimes you can have something called hypersplenism, where the spleen just kind of like entraps and yanks red blood cells from your bloodstream way faster and way more than it ever should. Usually, red blood cells get destroyed by your spleen whenever they're old and defective. But whenever your spleen is just acting up, and there's many different reasons it can do that. We're not going to go down that rabbit hole in this video. We'll do another one, again, on its own when we talk about hemolytic anemias. The spleen can just chew through the red blood cells, and it can hyperfunction and yank them all out, and it can get really big because it's chewing through them. So consider a splenic ultrasound when you have someone who has some big splenomegaly, and think about that if they have underlying splenic disease or liver disease. This will involve a lot heavier workup, which we're not going to go into right now. But that's something to think about, especially with the extravascular hemolysis. Okay, so you think they have hemolysis. Check an LDH, check a haptoglobin. You can also consider getting a splenic ultrasound to look for any splenomegaly to rule out hypersplenism. Got it? Okay, next thing I like to do after I've confirmed. So first thing is this. This is the first part. First part is your hemolytic labs. That's the first part. Second part is this autoimmune hemolysis? So that's the next thing I have to determine. So in order for me to do that, I have to do something called a direct antibody test. Sometimes we call this a Coombs test. And what I want to know is I want to know if my Coombs test is positive or negative. If the DAT or the Coombs is positive, I have something called an autoimmune hemolytic anemia. And again, with these, there's many different types of issues with these. So whenever we talk about autoimmune hemolytic anemia, there's an endless number of causes. We're not going to go down that rabbit hole. What I do want you to know is when you get these tests, what they tell you. So let's say that you do a DAT or a Coombs test. What you want to know is it a warm? First off, you want to know if it's positive. Okay, so if it's positive, you have an autoimmune hemolytic anemia. But then you got to go to the next step. So if it's positive, you have an autoimmune hemolytic anemia. But then you got to look at it a little bit more and determine if it's a cold autoimmune hemolytic anemia or a warm autoimmune hemolytic anemia. And the way that you do that is by the way that they're positive on their DAT or their Coombs test. In the warm autoimmune hemolytic anemia, their IgG is positive and their complements is positive. In the cold autoimmune hemolytic anemia, their IgG is negative and their actual complements are positive. So that's something to remember, but either way, they're both autoimmune hemolytic anemias. If you really just want to come down to the simplest point, you check for hemolytic labs, it's positive. You check a DAT, it's positive. If the DAT's positive, you do have autoimmune hemolytic anemia. If you want to figure out if it's hot or cold, you just look at the patterns of their IgG and their complements. If both are positive, it's warm. If only the IgG is negative and the complements are positive, it's cold. And that can kind of differentiate like your two different types of autoimmune hemolytic anemias. All right, so first thing, check your hemolytic labs. If they're positive, good. Move on to the second part, check for the DAT. If the DAT's positive, good, it's autoimmune. Look at the patterns, is it warm or cold? If the DAT is negative, okay, so then the third thing is, if the DAT is actually potentially negative, then you got to go down the rabbit hole of looking for another cause of their hemolysis. And so then that's when you try to determine, this is how I look at it. So if their DAT's negative, then I try to say, okay, they're hemolyzing now due to something else that's not autoimmune. So then I try to think about reasons why someone would actually get their red blood cells hemolyzed. Is it something wrong with the red blood cell intrinsically? Or is there something else that's actually working against the red blood cell extrinsically? So some type of trauma, is there some type of infection? Is there what's going on outside the actual red blood cell that could be affecting it? That's the way I look at it. So with these, it helps me to figure out my testing and what kind of things I should be thinking about. So if my DAT's negative, I think, okay, first let's think about intrinsic hemolytic anemias. So I think about the red blood cell. Is there something wrong with an enzyme inside of it? If that's the problem, the first disease I think about that you guys would probably want to think about here is called G6PD-H deficiency. So it's called G6PD-H deficiency. In this disease, you see this in younger African American children. Again, in this one, it's usually after they've had like an infection, they've been exposed to some type of like fava bean, like they were eating fava beans, stuff like that. But what you're looking at for these patients is you actually check this enzyme, and this enzyme level will actually be low. You only want to check it though when they're not hemolyzing. So that's one of the big things, like little caveats in this, is you only check for G6PD-H deficiency when they're not actually in hemolytic crisis, because whatever put them into it, you have to wait a little bit so they're a little bit healthier, and then you can check the enzyme. But what actually may come up on the exam is for these patients, after you get your DAT, I think the next two big things to look at is your peripheral blood smear and history. That's the next thing, so I would do that. So after the DAT's negative, the fourth step I would say is look at my peripheral blood smear and look at my history. So for this peripheral blood smear, what I would actually see for these patients is I would see something called bite cells, and we'll show you what those look like. And I could also see something called Heinz bodies. So if I see these, I have a concern of G6PD-H deficiency. If they're not in the hemolytic stage, I can check their G6PD-H level, and they'll actually have a significant deficiency there. All right, hemoglobinopathy. So if they have, again, a history of some type of hemoglobin problem, they have a history of sickle cell anemia, a family history of sickle cell anemia, they've had a history of vaso-occlusive crises, or they're having it right now, in that kind of sense, you can actually potentially assume it's a hemoglobinopathy. That's your history. But if we wanted to get a peripheral blood smear, what would the peripheral blood smear show if you had sickle cell anemia? You would see sickle cells. And if you actually were potentially, maybe this was their first vaso-occlusive event, and you actually potentially got the peripheral blood smear and you saw that there was sickle cells, you can actually confirm with a hemoglobin electrophoresis to show sickle cell anemia. And obviously that'll show the hemoglobin F. And in this case, you'll actually see like they'll have the sickle cell anemia potentially. So again, that's your hemoglobinopathy. So I think, is there an enzyme problem? G6PD-H, is there a hemoglobinopathy? Sickle cell anemia is a big one. Look for sickle cells, look for the history, any vaso-occlusive events, confirm with the hemoglobin electrophoresis. Is there a membrane problem? So with the membrane problems, I think about two disorders here. One is called hereditary spherocytosis. So with hereditary spherocytosis, usually these patients won't be super obvious. They won't have a lot of like symptoms or clinical features. But again, what's the next test? Peripheral blood smear and history. Nothing really special about their history. But if you look at their peripheral blood smear, they will have spherocytes. So a lot of these like spherical shaped cells. What you'll do is if you're concerned, you can do something called an osmotic fragility test. And if their osmotic fragility test is positive, you have a very high degree of suspicion for hereditary spherocytosis. Okay? The next disease that you should be thinking about here is actually called paroxysmal nocturnal hemoglobinuria. So in this disease, it's actually odd because at night they actually kind of go through these hemolytic events. And they have particular like mutations in very specific proteins in their cell membranes. What you want to look at in their history is they've had some type of history of like clots, like lots of actual venous clots. So maybe they had like DVTs and PEs or Budd-Chiari syndrome. So look for like history of like venous types of clots, especially like Budd-Chiari syndrome or something like that. Then again, look at your peripheral blood smear. On the peripheral blood smear, they will have spherocytes. But one of the key things here is not only will you have a history of venous clots, but they'll wake up, they'll actually, in the morning, they'll have dark urine in the AM, okay? So they'll wake up in the morning and they'll have dark urine in the AM. They'll also potentially have history of venous clots. You get a peripheral blood smear, it shows spherocytes. If you have this high degree of suspicion with some of this history in spherocytes, you should consider sending off a very specific test called a flow cytometry. So you can do something called a flow cytometry, and if that is positive, then it's very suggestive of paroxysmal nocturnal hemoglobinuria. All right, so that's the way I would go through that. Is it hemolysis? LDH, haptoglobin. That comes back positive. Is it autoimmune? DAT, Coombs. Is that positive? Okay, autoimmune. Which one? Warm, cold. Boom. If it's negative, okay, is it an intrinsic problem? Get a peripheral blood smear and look at their history. Figure out if it's an enzyme, hemoglobinopathy, or a membrane problem. If you've gone through all of these and you can't find it, then move on to your extrinsic problems. All right, so for these bad boys, you can think about something called microangiopathic hemolytic anemia, MAHA. And what this is you're actually having a red blood cell problem, but also look for low platelets. So the other thing I would actually tell you to look at is what is their platelet count. Because if their platelet count is dropping, sometimes we call these like thrombotic microangiopathies. This can actually be sometimes very helpful. So if you see a drop in their platelets, think about microangiopathic hemolytic anemia. The basic concept behind this is that you are actually having some type of like small clots. So the basic theory behind this is you have these vessels here and they have like small clots here. And as like your red blood cells and as the platelets are trying to kind of like squeeze through, like they're getting kind of consumed up in these clots, they actually can get consumed or they can get ripped apart as they're bumping up against these microthrombi. The other thing is that sometimes if people have like heart valves, those can actually kind of rip, they can rip like a mechanical heart valve and you're pushing blood against it. Sometimes red blood cells can just get sheared apart on that as well. So I think one of the big things to look for MAHA is there's a couple different disorders. First off, look for the low platelets. Then you want to think about a couple different types of MAHAs. The first ones that you want to think about is DIC. Then you want to think about something called TTP. Think about HUS. Think about HELP syndrome. And then lastly, you want to think about some type of mechanical valve. All right. So DIC is disseminated intravascular coagulation. And these patients, all of these, they're kind of like having like somewhat of these low platelets and low red blood cells because of these multiple microthrombi. In DIC, some of the cueing kind of features here is that usually the patient is like septic or critically ill, and they have like elevated coagulation kind of problems. So they have like an elevated PTT, a PT, an INR, they have like an increased D-dimer, they have like a low fibrinogen, and they have like the low platelets. And they're really sick in these patients. That would be kind of one of the cueing factors for that one. For TTP, you would also have these patients who have, again, low platelets. They would also have acute renal failure. They would also have this actual drop in red blood cells. And they would have some type of like fever, potentially, and neuro deficits. So these are something to think about as well. And if you do have a high degree of suspicion for TTP, sometimes you can confirm that with the ATOM T13 testing and look to see if there's some type of like deficiency there as well. HUS, usually hemolytic uremic syndrome. This is more common in like your children, your younger kind of children, but there's some type of like prior like GI infection, usually by like what's called the Shiga toxin. But these people will also have low platelets. They'll have some type of acute renal failure. And again, you'll have evidence of anemia, but probably some type of underlying history of GI issues prior to that. So think about that in younger children. For HELLP syndrome, you obviously have to think about like a pregnant woman, okay? So think about a pregnant woman, that's one particular big thing. And then if you think about it, HELLP syndrome is hemolysis, and then they're gonna have low platelets and elevated LFTs. So they'll have low platelets and increased LFTs. And then again, in a pregnant patient. So that's another big thing to think about for these types of MAHAs. Mechanical valve, if they have like a mechanical aortic valve, this can actually chew up their red blood cells. So that's one particular thing to think about. Now, how do I can obviously think that it's one of these, but how do I really kind of get down to business for these? Because you said, Zach, check a peripheral blood smear and think about the history for these. Well, for the peripheral blood smear for these, it's actually relatively helpful. So the peripheral blood smear for all of your MAHAs, so we're gonna put it right here, the peripheral blood smear will show something called schistocytes. And these are just like torn up red blood cells. Sometimes you can see these things called helmet cells as well. But I think this is the big thing here is the schistocytes. So if you see a patient has schistocytes, torn up, ripped up red blood cells, think about some type of MAHA, and then look, do they have low platelets? That also suggests a MAHA. And then you can think about which one it is based upon their history. Do they have a history of an aortic, like a mechanical aortic valve? Do they have any of these findings of DIC? Do they have any of these findings of TTP? Do they have any of these findings of HUS? Do they have any of the findings of HELLP syndrome? And that will kind of lead you down that road of which type of problem it could be. Not too bad, right? All right. Next one is infectious. Now, infectious is a kind of a super obvious one. With infectious ones, you want to think about a patient who is having a super high fever. For all of these patients, they're probably gonna have some type of high fever, maybe like a rash of some kind. And this is a really important one. Okay, for these ones, you wanna think about malaria. Okay, you wanna think about malaria. So in this situation, obviously in their history, they have some type of recent travel to like Africa or some kind of area where there's a high possibility of being exposed to malaria. And then they come back with a high fever, they come back with fatigue, they come back with a lot of myalgias and things of that nature. When you look at the peripheral blood smear on these patients, you'll be able to see the inclusions of the actual malaria inside of them. So you'll be able to see the inclusions inside of the red blood cell. They get inside of the actual red blood cell. And so you'll be able to see that on this one, on their blood smear. The other one you want to think about is something called babesiosis. So it's called babesiosis. So usually this is due to a tick bite. So if you look in their history and they have some type of tick bite, they have like a rash, they have high fevers, they were in an area like Wisconsin or something like that, then they could have been it could have been a potential babesiosis. So in these situations, their peripheral blood smear can actually show something that's very pathognomonic called a Maltese cross. So look for this one as a big one for babesiosis. And the last one is called disseminated C. diff. Really nasty stuff here. If someone gets a really nasty Clostridium difficile infection, so they have like just rip-roaring diarrhea, just peeing out their bunghole, in that kind of situation, they look septic, they're really sick, high fevers, lots of diarrhea, then I would actually go ahead and again, look at their peripheral blood smear, test for C. diff, obviously. And in this situation, they have something called ghost cells that pop up for C. diff, okay? But test for C. diff, obviously you can check their peripheral blood smear, look at their history. But again, I think one of the key things that clues you to think about fevers, think about the infectious causes, is very high fevers, rashes, some type of recent travel into areas where there's a high exposure, or again, potentially like with C. diff, lots and lots of diarrhea potentially. All right, so that's how I go about these. So real quick again, you check for hemolytic labs, haptoglobin, LDH. If it's positive, check the DAT. If that's positive, it's autoimmune. If it's not, then look at your, again, peripheral blood smear and history and figure out if it's intrinsic or extrinsic. From there, we've gone through all of our, oh, and then lastly, again, if you think that there could be some type of hypersplenism, check the spleen for splenomegaly by doing a splenic ultrasound. All right, now that we've gone through these, let's talk about the last part here that could be a part of these anemias, though it's not destruction, it's a loss of blood. Let's talk about that. All right, so the last thing is we think it's blood loss. How do I determine that? So first thing I would actually do is I would say, okay, I know that it's, again, I have anemia, low hemoglobin, low hematocrit, low red blood cells, check my retic index, greater than 2%. I know it's an increased destruction or loss problem. How do I know that it's not actually a destruction problem? What did I tell you to first check right away? The first thing you check is for hemolysis. So if in these patients, the first thing you see is there is no evidence of hemolysis. So in other words, their LDH is normal, their haptoglobin is normal. You don't have to go down the direction of checking a DAT and then looking for any of these intrinsic and extrinsic hemolytic anemias. You're done. You already know it's not hemolysis. I can move on and say that it's likely blood loss. Plus, here's the thing, my friends, be intelligent. If someone is losing blood, you can look at their actual physical exam. So do they have any signs and symptoms of bleeding? Do they look pale? Do they have pallor? Do they have dry mucous membranes, decreased capillary refill? Are they having hypotension, tachycardia? All evidence that they could be losing blood and evidence of bleeding right in front of you. You know, look at those things. But if you kind of look at this systematically, they're negative for hemolysis and they have some types of concerns for bleeding. They're on anticoagulants. They just had a recent procedure done. Think about those things. And I think the first thing right away, which you're probably going to experience a lot of the time in your clinical world, especially in the ICU in the hospital, is you're going to look and you're going to be like, oh my gosh, this patient is like anemic. And you're going to look and it's because they've been getting blood draws every single day, multiple blood draws every day, and that's why they're anemic. So sometimes if you were to go down the rabbit hole of saying, okay, I see the patient's anemic, I check their hemolytic, I check their retic, it's greater than 2. Okay, then I go ahead and I do the next thing and I check to see what their, I check their hemolytic labs, they're negative. Oh, okay, potentially from blood draws. So could it be from just frequent blood draws? That might be their reason, especially if they have no obvious other source. The other thing is, was there any particular surgery? So sometimes was there a recent surgical procedure that they lost blood? The other thing I think where you lose tons of blood is what we talked about is the GIT. You can lose tons and tons of blood from the GIT. So GI bleeds are sons of guns. So look for any evidence of vomiting up of blood, right? Hematemesis. Look for any bright red blood per rectum or melena, dark stools. And if you have potential concerns of these, then what you can do is you can actually do something for the upper GI. You can do like an EGD, and that will be able to tell you if you have some type of like upper GI bleed. Sometimes they can even do what's called a nasogastric tube, and then they can aspirate out some areas from the gastric tube and see if there's any blood in there after you lavage it and then aspirate some stuff back. But I think the EGD is probably going to be the best. And if that's positive and you find something within the esophagus or the stomach or proximal part of the duodenum, then you're done. If it's a lower GI bleed, you maybe need like a C-scope. So maybe you have to do like a colonoscopy and that's going to show you your lower GI bleed. Or maybe you do a fecal occult blood test and you find that's positive. When you test their stool, you do like a digital rectal, put it on the little thing and it shows up positive for blood. That could be a potential problem. So these are things to be thinking about. Now, the other thing that I would say is a really big one that I've experienced a lot of the times that can cause just massive blood loss is what's called retroperitoneal bleed. So you know there's a little space behind your peritoneum called the retroperitoneum. You can lose a lot of blood from it into these areas here, especially if you have like any kind of aortic bleed, you have a small vessel bleed within the leg, you're on anticoagulants. So really be on high alert for patients who have what's called a RP bleed. And that's a big one. And sometimes for this one, we do something called a CTA of like the abdomen and the pelvis area. So you can do a CTA of the abdomen and pelvis to look for any kind of bleed in that areas. You know what else? Sometimes if people kind of like hit like an artery in their leg, like they fracture a bone or they get some type of procedure, you can actually accumulate a lot of blood within the leg too. So take a look at their legs. Do they have any swollen legs or hematomas, any visible things there? That's also important too. But I think that really just gives you the basic idea, my friends, of how to approach anemia. What I want us to do now is put this to practice. Let's see if you remember this stuff. So what we're going to do is we're going to do some case studies and see if you can determine which type of problem it is with this increased destruction category. Case study 9. Okay, here we go. We have a 75-year-old male, status post mechanical thrombectomy. They had a stroke, and they had to go in through like the femoral artery to go up and try to pull the clot out of one of the vessels. Comes back and then has later a hemoglobin of 6.8. So he's anemic. What do we got to do? Check the retic. Retic is 7%. It's greater than 2%. What does that mean? It's not a decreased production problem anymore, my friends. This is a what? It's either an increased destruction or loss. What do we have to do to make sure it's either an increased destruction or a loss problem? We got to check for hemolysis. How do you check for hemolysis? You got to check your LDH. You got to check your haptoglobin. But you can also check your indirect bili. They're all normal. If those are normal, is there likely hemolysis? No, there's no hemolysis. So what is it likely? It could be a bleed. What do we have to look for? Signs and symptoms of bleeding. So they just had a mechanical thrombectomy. They have a big fat hematoma on their hip. And they're hypotensive. They're tachycardic. They look pale. You send them to get a CT abdomen pelvis because you think they have an RP bleed, and there the arrow's pointing at it. There's a bunch of blood sitting there after that procedure. You confirmed it. Now what do we know? It's an RP bleed that caused their anemia. Boom. Straightforward, right? Okay, let's move on. Case study 10. You get a 75-year-old male, past medical history of CLL, chronic lymphocytic leukemia, presents with a hemoglobin of 8.9. That's anemic. What do we got to do? Check the retic. Retic is 9. What does that mean? It's not a decreased production. It's an increased destruction or loss problem. How do I determine if it's an increased destruction or an increase in loss? Hemolytic labs. My LDH is high. My haptoglobin's low. My indirect bili is high. That's evidence of hemolysis. What do I check after hemolysis is present? A DAT. Why do I check a DAT or a Coombs test? To see if it's autoimmune. DAT's positive. And it's positive for IgG and positive for complements. Which one is that? Is that cold or warm? That's warm. If it's a warm autoimmune hemolytic anemia, there's a bunch of different causes behind this, but it's likely the CLL that's probably the culprit behind that. Okay, we'll go into more of the causes and all the details of that in individual videos on these anemias. But for right now, that's the basic concept. All right, good job. We're moving along, guys. All right, 75-year-old male. Cough, shortness of breath, green sputum, presents with a hemoglobin of 9.9. He's anemic. Check the retic. 6%. It's greater than 2. It's either increased destruction or increased loss. What do we do? Hemolytic labs. Oh, he's got hemolysis. What do I do? Check a DAT. Why do I check a DAT or a Coombs? To see if he's got autoimmune hemolysis. It's positive. Their DAT, actually, Coombs, is negative for IgG, but it's positive for complements and IgM. So he does have a positive DAT, but it's only positive for the, again, complements. What was that one? That was a cold autoimmune hemolytic anemia. And it's likely secondary to mycoplasma pneumonia. And again, you can confirm that with a PCR. And again, we'll go into more of the details of these in individual videos, but at least you got that it was a cold autoimmune hemolytic anemia. All right. 12. 11-year-old African-American male, treated for pneumonia with Bactrim, decided to eat some fava beans for lunch. Presents with a hemoglobin of 10.2. He's anemic. What do I do? Check the retic. It's 4. It's greater than 2, so it's not a decreased production. It's an increased destruction or loss. What do I do? Check for hemolysis. There's hemolysis. What do I do? Check a DAT to see if it's autoimmune. DAT's negative. It's not autoimmune. What do I have to do now? Look at the peripheral blood smear and take into consideration his history. What's suggestive in his history? He's African-American, he's young, and then there was some type of oxidative stress. He was exposed to an infection with pneumonia. He was exposed to Bactrim, which is an antibiotic that can cause oxidative stress, and fava beans, which can kind of cause some problems. All right, let's look at what's the next thing, peripheral blood smear. What I tell you was the big words to think about: Bite cells and Heinz bodies. G6PD-H deficiency. What do you actually want to check for G6PD-H deficiency? The enzyme levels. But do you check it while they're hemolyzing? No, you have to check it when they're not hemolyzing. So check it again to see if when they're not in a hemolytic state, to see if it's low. What's my likely diagnosis? G6PD-H deficiency. Oh man, we're going. All right, next one. 12-year-old African-American male presents with chest pain. He's also got painful and pale extremities with hematuria. Hemoglobin 7.2. He's anemic. What do? Check a retic. Oh, 7.5. It's greater than 2. So it's not likely a decreased production. It's an increased destruction loss. How do I know which one it is? Check my hemolysis labs. Oh, he's hemolyzing. Is it an autoimmune? Nope. It's likely some type of intrinsic or acquired problem. How do I know? Look at the history and peripheral blood smear. History. He's young. He's African American. He's got chest pain, painful, pale extremities, and hematuria. Huh. Could it be like a sickle cell kind of crisis, like a vaso-occlusive crisis? It could be. How do I kind of add on to that? Peripheral blood smear. What does it look like? Sickle cells. What do I likely have? Sickle cell anemia. How do I confirm it? Hemoglobin electrophoresis. It's positive. What's my diagnosis? Sickle cell anemia. Woo! 44-year-old female with past medical history, Bud Chiari, has dark urine in the morning. Presence of the hemoglobin at 10.5. Anemia. What do? Check a retic. It's 2.5. It's high. It's greater than 2%. Is it hemolysis or is it a destruction? What do I got to do? Look at my hemolytic labs. There's hemolysis. Is it autoimmune? Check a DAT. It's negative. Look at my peripheral blood smear and consider my history. My history, they have Bud Chiari syndrome. That's a venous clot within the hepatic veins, and they have dark urine in the morning. I can look at my peripheral blood smear. Sometimes it'll show spherocytes, but sometimes it's unrevealing. Oh, it's unrevealing. I have a suspicion of what? Paroxysmal nocturnal hemoglobinuria. What do I have to use to confirm? Flow cytometry. It's positive. What do I have? Paroxysmal nocturnal hemoglobinuria. All right, next one. 22-year-old male with no past medical history that's pertinent for anything presents to the office with a hemoglobin of 9.5. Okay, nothing special, but he's anemic. What do? Check a retic. It's 5.5. Increased destruction / loss. How do I know? Hemolytic labs. They're elevated. Is it autoimmune? That's negative, not autoimmune. What do I think I do? Peripheral blood smear and history. History doesn't really suggest anything. What does this peripheral blood smear show? Oh boy, these are spherocytes. If they're spherocytes, what do I obviously want to consider? Especially with no person with a very significant past medical history, no venous clots, no kind of urinary, dark urine in the morning. Hereditary spherocytosis. With hereditary spherocytosis, what do I actually have to check? Osmotic fragility test. If I check an osmotic fragility test, it's positive. What do I have? Hereditary spherocytosis. All right, next one. 32-year-old female, no past medical history, presents to the office after a trip to Africa with high fevers and fatigue. Hemoglobin of 8.5. All right, they got anemia. Check the retic. It's elevated. Is it increased destruction or loss? How do I know? Check my hemolytic labs. They're elevated. Is it autoimmune? Check a DAT. It's negative. It's not autoimmune. Then what do I got to do? Look at my history and consider my peripheral blood smear. History. What do I see here? High fevers and fatigue. Trip to Africa. That's interesting. Look at my peripheral blood smear. I see inclusions inside of these, and they don't look like a cross, like a Maltese cross. And I have a trip to Africa with high fevers and fatigue. I think it's malaria. This is classic Plasmodium falciparum. So I got malaria. All right, next one. 29-year-old female, no past medical history, presents to the office after a hiking trip to Wisconsin. Came back with a rash, high fevers, and fatigue. Hemoglobin's 9.5. She's anemic. Check the retic. It's elevated. If it's elevated, I know that it's increased destruction or loss. How do I know if it's which one? Hemolytic labs. They're elevated. Is it autoimmune? That's Coombs negative. Therefore, I have to look at my peripheral blood smear and history. History. What do I got? High fevers. I got fatigue. I got a rash. And I got a trip to Wisconsin where there's potentially ticks. What do I got to do? Get a peripheral blood smear. Look for a Maltese cross. Look at that Maltese cross. What's that pathognomonic for? Babesiosis. All right. 65-year-old female who's acutely ill, has sepsis, hemoglobin 6.5, has low platelets or thrombocytopenia. You also have other labs like a high PTT, a PTINR, a D-dimer, and then they also have a low fibrinogen. Again, what do I always have to check? They're anemic. Check a retic. Retic's 10.1. There's an increased destruction or loss. How do I know which one? Hemolytic labs. They're elevated. Is it autoimmune? Check a DAT. It's negative. Look at their peripheral blood smear and history. History suggests that they are very ill. They have low platelets and they have a very significant kind of coagulopathy here. Let's check their peripheral blood smear. They have schistocytes and helmet cells. That's suggestive of a MAHA, a microangiopathic hemolytic anemia. Do they have a mechanical valve? No. Do they have any kind of recent kind of like diarrhea along with acute renal failure? No. Are they pregnant? No. Is there any kind of like coagulopathies present? Yeah, look at all that. This is likely DIC. It's unlikely TTP. It's unlikely HUS. It's unlikely HELP, and they don't have a mechanical heart valve that's mentioned here. So it's likely DIC. So it's a MAHA, likely secondary to DIC. All right. 65-year-old female, past medical history of non-Hodgkin's lymphoma, presents with abdominal fullness and a hemoglobin of 7.7. All right, what do? Check a retic. 8.1. Increased destruction / loss. Which one? Check hemolytic labs. The hemolytic labs are high, but they're borderline high. So they're not crazy high. Remember what I told you? If you have somebody who's hemolyzing, they have evidence of hemolysis, but it's just barely elevated, and they have this abdominal fullness. What do I tell you to potentially consider? Think about the spleen, right? Maybe, but we know we're in the hemolytic area. All right, so we can continue to move forward. It's barely elevated. All right, what do we always got to do? Make sure it's not autoimmune. Check a DAT. DAT's negative. Look at the history and consider your peripheral blood smear if you need one. In their history, they have non-Hodgkin's lymphoma that likes to involve lymphatic tissue. One of those lymphatic tissues potentially could be the spleen, lymph nodes, all that kind of stuff like that, right? All right, so if I have borderline hemolytic labs, DAT's negative, and again, they don't have like any history to suggest an intrinsic problem like G6PD-H or sickle cell or any kind of like membrane problem. I don't have any like low platelets or anything concerning for MAHA. I don't have any high fevers. What I tell you was something to think about. Consider checking that spleen. Maybe a splenic ultrasound wouldn't be a bad idea. But either way, we should check a peripheral blood smear, right? And check their history. Peripheral blood smear is unrevealing. What I tell you to think about at that point in time? Splenic ultrasound. You do a splenic and liver ultrasound, you find splenomegaly. You think that they have hypersplenism. All right, so guys, that covers all of these anemia case studies. I really hope that this helped. I hope it made sense. I know it was a ton of information, but my goal at the end of this is that you guys would understand this stuff and you would be able to take any question and dissect it with a very straightforward, systematic approach to get down to the bare nitty-gritty of what is the problem. And then what we'll do is, over some time, as we're going to go over every single type of anemia. We'll have a video on microcytic, macrocytic, normocytic, hemolytic, and so on and so forth, where we'll go into these in more detail. But Ninja Nerds, thank you guys for being so awesome. I love you. I thank you. And as always, until next time.